My name's Morag Taylah, and Lorraine Lovitt will be joining us from, she's currently in a meeting, but she's going to co-chair with me. So we're going to start the afternoon concurrent session on ageing services. So just welcome to everyone online who's live streaming in. And you can ask questions on Slido, but I believe these are going to be given to the presenters after, and they will answer those questions. So first up, we're going to have Dr. Meghan Ambrens. She's a postdoc from Neura, and she'll be presenting on co-creating an optimal implementation model for digital health solutions into community aged care, the implementation of an eHealth fall prevention program. So welcome, Meghan.
Hello everybody. Thanks for the opportunity to present this work. It was funded by the HCF. So I think we'd all agree that falls and mobility impairments are common among older people. And I think they'd probably also all agree that they have an impact on their health and well-being. I'm going to click lots. Nothing's happening. I'll click with Mark. There we go. That these health and mobility impairments have an impact on well-being in this cohort of people. And actually also I think we probably all agree that it doesn't like me very much, guys. There we go. That falls can be prevented with appropriately designed exercise programs. However, many older people do not receive the allied health support that they need to maintain their mobility and safety at home. The Australian Royal Commission into Aged Care Quality and Safety found that waiting times for a home care package are between 7 months and 34 months. This means that many older people actually enter residential care or die before they receive a home care package. That is a concern, and one that could be met by integrating digital technologies into community aged care, especially for those living in rural and regional areas where there's a more pronounced gap in services. Digital health programs can improve service reach, they can contain costs and maximise the use of limited human resources. However, widespread adoption of digital health programs depends on the seamless integration into existing healthcare workflows. So this study aimed to co-design an optimal implementation model for digital health solutions into community aged care. We specifically wanted to understand the barriers and facilitators associated with implementing this model, and we wanted to select targeted strategies to address these barriers and facilitators, and then that led to a model or an optimal implementation model to support the delivery of a digital health program into community aged care. Our outcome was obviously the development of an optimal implementation model, and we collected data through interview and focus groups over 6 months. Before I present the results, I want to give you a quick overview of the digital program that we used as an example. Standing Tall, you briefly heard about it this morning with Rick's presentation, is a technology delivered or driven exercise program with proven effectiveness to prevent falls and improve mobility in older adults. It provides exercises that are focused on standing, leaning and walking balance, a reactive stepping and obstacle negotiation, as well as functional strength and cardiac health. So the results of this study. We used the Consolidated Framework for Implementation Research, commonly referred to as the CIFA 2.0, to assess the barriers and facilitators influencing the implementation of the Standing Tall program into community aged care. We had 3 key themes that emerged. The first was sitting around modifications to the program, so Standing Tall, to ensure it suited the setting. There were themes around organisational support for healthcare professionals who were seen as the deliverers of the program, and then modifications to the organisational process. When we mapped these against the CEFA, the inner setting and the individual domains of the CEFA were the two that were mapped against. Let's start with looking at the inner domain. So, health professionals reported that clients they didn't have a suitable device at home. There were also practical challenges related to technology infrastructure for the health professional. Many of them rely on hotspotting off their mobile phone for a Wi-Fi connection to their work laptop. And these presented barriers to setting up the program as well as supporting the program. There was also strong preference for Standing Tall to be integrated into the organisation's electronic medical records for long-term sustainability, and also to reduce the burden of documentation, which is considerable for this setting. Healthcare professionals identified that funding was a critical facilitator for implementation. They wanted organisational support to fund training time as well as additional setup costs. So that the time to set up the visit to set up the Standing Tall program. But time pressures and limited flexibility in schedules were a major concern for a time-poor workforce. Despite agreement that Standing Tall was a high-quality evidence-based program, there was evident tension for change and concerns about its compatibility within existing care models and funding structures. Without a clear catalyst for change, healthcare professionals questioned how the program would fit within their current work practices or workflows. There was also relative opportunity as a concern. In many organisations, somebody called the clinical care manager, whose responsibility was to oversee the funding for the allocation of funding for home care packages, was typically they're typically the person that the healthcare professional would go to seek approval for before visiting a client, and also the person that the healthcare professional would go back to recommend services. Care professionals told us that the workload for a clinical care manager was considerable, and that meant that clinical care managers tended to have a very short-term focus and short-term priorities, and that raised concerns about whether something like Standing Tall would be funded by them. We shift now to the individual domain. Technology literacy to use a digitally delivered exercise program emerged as a key barrier. As the innovation deliverer, the healthcare professional plays a critical role in introducing the innovation, so the program, to the client, and also determining when and how a client is introduced to the program. Many healthcare professionals perceived that their clients, who were typically aged 75 years or over, lacked the necessary skills to use a digital exercise program. This perception, coupled with the lack of devices that I said they tended to have, results really in a reluctance by the healthcare professional to recommend or trial the program. In addition, healthcare professionals themselves expressed low confidence in their own technological literacy, so that further impacted their willingness to adopt and deliver the program. Client adherence to prescribed exercises was also identified as a barrier. Healthcare professionals reported ongoing challenges with adherence with their clients in exercise delivery. Typically, what they give their clients were hand-drawn pictures with a small diagram left in an area, like a high traffic area of their house, like, visible on the fridge. And so this would be a big switch for them. Once we mapped, I'll give you a quick look at that, sorry. Once we mapped, the next step of this was to map these facilitators and barriers against something called the CEFA ERIC matching tool. So the C4ERIC matching tool selects targeted implementation strategies that address identified barriers to inform what we are hoping will be a final implementation model. We found there were 6 strategies. The first one is to identify and prepare champions. So this strategy was chosen to address barriers related to resistance to change, low confidence in using technology, and limited capacity for peer support within care teams. The next one, Build a Coalition, was selected to address limited organisational buy-in, funding constraints, and a lack of alignment between priorities and across the organisation's different roles. Promote Adaptability was chosen to address concerns about compatibility with existing workflows, funding models, and client care pathways. Conduct Ongoing Training was chosen to address low confidence, staff turnover, and the need for refresher learning opportunities. Develop an educational materials was chosen to address low confidence in literacy and technology use, including lack of client and carer understanding. And the final one, Develop a Formal Implementation Blueprint, was chosen to address the uncertainty about workflows, how and when to deliver the program, and concerns about funding and resource allocation. These strategies offer what we hope is a balanced mix of individual level and organisational level interventions to support both the workforce readiness and system integration. By focusing on these core strategies, the model prioritises what has been tested and refined in practice, while leaving space to explore additional strategies such as facilitation, tailoring, learning collaboratives in subsequent phases of implementation. Our next step with this model is to test it through a validation and a refinement through a 6-month pilot study, which we hope will provide critical insights for scaling the digital health intervention across this sector. I mentioned really earlier on, this is my team. Nobody can do anything without a team. And I mentioned earlier on, Standing Tall was the program that we used to as the example. If you're interested in finding out more about Standing Tall, that is a QR code will take you to that website that's listed there as well. But yeah, that's all I have. Questions?
I just wondered, thank you, that was a really interesting presentation. Is there a paper with...
Soon, yeah.
Oh, great.
The paper's written. We haven't published it yet, but we will hopefully, it should get submitted in the next, days away from it's ready to submit. So then it'll just be about however long it takes to land in your lap from the time I hit submit. But yeah, you're welcome. So you can reach out to us, come and find me. Happy to give you, or Kim, who is my manager, who designed Standing Tall. Happy to chat to you. You can keep in the loop with us through Standing Tall website, or but yeah, yep.
Any other questions? I've got a question.
Yeah.
How many organisations were involved in the co-design, and do you think all organisations are the same in terms of the challenges they'll have?
Thanks for asking. I realised when I was talking to you guys that I hadn't said 3 organisations we used to help us develop this. So 3 different all aged care, 2 quite big ones and 1 smaller one, and everybody has a different story to tell. Different. You guys probably know even better than me how complex the aged care system is, and funding that sits around that, and that and then when you layer an organisation over the top of that, it can get harder. And this group of health professionals works really hard and is really constrained by what they can do. And so each of the organisations, we had primarily physio and allied health physio and the allied health assistant at 2 of them, and then some OT mixed, and OT and EPs mixed in that across one of those 2, and then the third organisation was all EPs. And we looked at different groups of people interacting, like maybe they were all going to one of the gyms within the accessing this aged care service gym, or accessing restorative care programs, so there were differences in who the allied health professional was, and that had implications to the program acceptance and implementation. There were differences in the organisational structures, and there were differences in who we tested it with. Yeah. I'm going to stay
Thanks,
up here.
Megan. And you can stay up there because Megan's giving us our second presentation on improving healthcare delivery to older patients following an ambulance call-out, implementing an evidence-based approach to prevent falls and reduce frailty.
Thank you. So again, thank you for the opportunity to present this work to you today. This one was funded by UNSW Ageing Futures Institute. We looked at a bit of a different study, some similar things in terms of the methodology though. Falls and frailty are a global health concern, and they have serious implications for clinical practice as well as public health, increasing the risk of hospitalisation, long-term care and mortality. Approximately 1/3 of community-dwelling adults over the age of 65 every year have a fall, and 22% of them suffer recurrent falls. While most reported fall-related injuries are minor, up to 15% of these are more serious and they end up in hospital. In Australia, falls accounted for 77% of injury hospitalisation and 71% of injury-related death in 2020, and we expect with an ageing population that these statistics will increase. In New South Wales, falls are the most common reason a paramedic is called to the home of somebody aged 65 years or over. In fact, they're called every 5 minutes. While most patients are transported to hospital, approximately 1/3 are not. And it's this 1/3 that I want to talk to you about today. So linked data found that falls patients are the largest group of people that are non-transported to hospital by a paramedic, and they're also the most likely to require another ambulance visit within 24 hours, and 55% of the time that second visit, is because of that original fall. In response to this, in 2018, the New South Wales Ambulance implemented a protocol called the Older Person Protocol, which combined a paramedic-developed screen for frailty. They called it the Elder at Risk screen, and with something you're probably aware of, the fall risk for older people in the community falls risk assessment. They use the short version of that. While this protocol together shows feasibility, they use it, right? This first one, the Elder at Risk screen, is not evidence-based, so it lacks the sufficient detail to effectively guide referrals for frailty and fall prevention. Research tells us that evidence-based practices, are essential to enhancing patient outcomes as well as reducing healthcare costs and minimising harm. So, with an increasing prevalence in frailty and falls due to an ageing population, it's imperative that we look to adopt evidence-based validated screening tools. The Clinical Frailty Scale is a validated, reliable tool for measuring frailty in people aged 65 years and over. Therefore, this study aimed to assess the feasibility and utility of the Clinical Frailty Scale in addition to, so the new combination is the FROPCOM and the Clinical Frailty Screen. What we wanted to understand, these are both validated tools in their own right. We're not interested in validating them, we're interested in understanding whether they're feasible for this setting. So what we did was conducted a mixed methods feasibility study in collaboration with New South Wales Ambulance, where paramedics were asked to use the FROPCOM and the Clinical Frailty Scale with patients aged 65 years or over who were deemed clinically safe to leave at home following call from that call out from the paramedic. We recruited paramedics working out of Lismore Station. However, in 2023, when this study started, industrial action also started. This resulted in really poor engagement with our study. So what we did was expanded our reach and invited paramedics from Tweed Heads, Kingscliff and Campsie, which is a metro station, to participate. Across these 4 stations, we had 30 paramedics registered to participate in our study. Engagement with the study improved in this second wave of recruitment, and this might be likely due to stronger leadership and communication by a designated study champion. We used survey and focus group to collect the data, and we had 13 participants complete the survey, which looked at feasibility, acceptability and appropriateness of the Clinical Frailty Scale, and 9 participants complete a focus group with us. Let's have a look at the results for the focus group. As far as effectiveness goes, paramedics reported that the Clinical Frailty Scale provided greater value and clinical utility than the Elder at Risk screen. They described it as more comprehensive and capable of capturing patient decline. They found that the CFS enhanced clinical decision making and it was a meaningful measure of frailty for them. However, the utility of the CFS was seen to depend on the availability of appropriate referral pathways. And without this link to a referral pathway, paramedics questioned the value of implementing it. Acceptability. The CFS is available as a downloadable app, so the paramedics downloaded it onto their phones, and they thought that they said that they really liked that, and that they found the app stepped them through the screening process very easily. However, they were dissatisfied with the training that they received on how to use the CFS, and many felt that it was the training too long, and talked about how often they preferred to rely on peer learning to use a new tool over more official training delivery. As far as appropriateness goes, they considered the CFS was more reflective of the patient's true condition than the previous tool, and they talked about how it prompted a deeper clinical assessment and was a useful guide for decision making. Despite this, paramedics noted that it did not capture access to social support and services well. As far as feasibility goes, so this combination of the CFS with the FROPCOM was considered effective for them in practice in the setting. Results from our survey. So we had 13 paramedics complete the survey, and they indicated high levels of acceptability, appropriateness and feasibility, although none of these were statistically significant. The points that I can pull out for you were that in the what one's that one? Seams, fittings, that seems suitable. So they thought that the CFS seems suitable as far as a measure of appropriateness goes, and then for feasibility, that it seems possible and that it seems doable. So those three were the highest scores that we got across that survey. They also talked to us about their current role and the system constraints that they face. Paramedics have evolved over time. Once upon a time, they told me that they used to be the place, they call, we haul, was what a quote they told us was. So they've become more than just a taxi to the hospital. They have become a health professional that's integrated within the broader system. Their role has expanded to include an assessment that extends beyond the assessment of physical injury. Despite these enhanced skills and responsibilities, paramedics frequently encounter service gaps, especially in regional areas, and this tends to result in more transport to hospital of patients that might not need to go, especially where there's an absence of a referral pathway. However, they acknowledged, despite saying that we probably take them to hospital more than we should, they said they acknowledged that that contributes to the system inefficiency. Barriers to referral pathways that we discussed. So they identified substantial variability in referral options across the regions, with rural and remote areas facing the greatest limitations. After-hours service availability was also a major concern. It might shock you to find out that people don't just fall between Monday to Friday, 8 a.m. to 4 p.m. It's not the falling time. It's often the time that health services are available though. So what happens after those hours? Paramedics don't have the answer for that. So it limits their ability to refer patients. Another consistent barrier identified was the lack of clear communication and handover between services. Often paramedics could not really verify whether referral plans were followed up or who was responsible for them. These findings reflect the urgent need for more equitable and coordinated referral services, particularly for older people in rural areas and also after-hours services. Facilitators of effective referral pathways. Paramedics working in metropolitan areas had a bit of a different story to tell us. They reported greater access to a range of referral services. They talked about options for eHealth services, RPAs, virtual, the VCCC, private hospital outreach programs, and the Geriatric flying squad. Crucially, the relationships built with these services were described as collaborative and patient-focused, and paramedics felt supported in making clinical decisions that respected patient autonomy. These findings underscore the importance of service availability, communication, and a team-based care model that enables paramedics to deliver community-based, person-centred care effectively. So, recommendations. Accessibility was seen as critical, with calls to integrate the CFS into devices and existing systems and embedding it into their electronic medical records system. They were all considered essential. Paramedics said effectiveness of the CFS is dependent on its integration with timely and appropriate referral pathways. Linking the CFS scores directly to actionable referral options would strengthen its clinical utility. Further work, though, is needed to develop and coordinate these pathways, especially in rural and regional settings and after-hours services. I'm almost there. Training delivery was a consistent concern. What currently happens is paramedics access training in their own time after hours, and or rely on peer learning. Sometimes some paramedics talked about resistance to change but thought it was overcomable. Successful implementation will require, robust systems, tailoring, training and integration into work systems, and they talked about the buy-in of people like extended care paramedics who ideally, as early adopters, would ideally lead implementation, and staff who were sitting on alternate duties or injury were potential kind of facilitators of a rollout. So my conclusion is that the study showed us that the CFS alongside the FROPCOM is feasible, acceptable and an appropriate tool for paramedics to assess frailty and falls. It enables structured evidence-based assessment and supported clinical decision making, and a full impact of it though would depend on an effective referral pathways, clinical practical training and integration into the workforce.
Great, thanks Megan. I think we've got time for one quick question.
No? Yes.
Hi, thank you for that. I might have missed some of this earlier, but I was interested in how was the CFS and documentation integrated into the documentation they have to do already, particularly in terms of going from using the app to putting it into their notes and other forms they might have needed to do.
Yep, the answer was in this little trial it wasn't. What they normally do with the elder at risk screen is it sits around, it's actually a KPI for them, and they have within their system, they have to tick that they've gone through that screen with people. So they want that would, with a statewide rollout, which is what the plan is of the CFS, that would be how it would be integrated, I think. So it would become a tick box that's attached to KPIs for them. Yeah.
So now I'd like to invite Taylah Pepper, who's a dietitian at the Centre for Strong Medicine from Concord Hospital, up to give her presentation on reducing malnutrition and frailty risk, the impact of dietitian intervention in a multidisciplinary geriatric service.
All right, thank you everyone. As mentioned, my name's Taylah Pepper and I work as a dietitian in the Centre for Strong Medicine at Concord Hospital. Today I'm going to be talking about the impact of dietitian intervention on malnutrition and frailty risk in older adults through the lens of Strong Concord, which is a geriatric multidisciplinary outpatient service. I'd like to acknowledge my co-authors for their contributions to this evaluation. So as we all know, the population is ageing and the growing chronic disease burden is seeing more adults presenting to hospital following a fall. In Australia, falls are the most common cause of hospitalisation among adults over 65 years of age, with approximately 1 in 3 adults falling every year. Falls have modifiable risk factors and outpatient multidisciplinary teams are well placed to manage these to reduce the likelihood of falls and associated hospitalisations. One of the most modifiable risk factors for falls is frailty. Falls and frailty share many risk factors, such as reduced function, polypharmacy, and weight loss. The 2017 Asia Pacific Clinical Practice Guidelines have 7 recommendations for the management of frailty. I'm going to focus on 3 of the recommendations that link directly to falls, and that is the inclusion of a progressive and individualised physical activity program, polypharmacy, and also screening patients with unintentional weight loss and considering supplementation or food fortification where necessary. These 3 recommendations see the basis for a multidisciplinary team with the ability to manage frailty and falls risk factors. Malnutrition is another risk factor for falls, frailty and hospitalisation. It's an increasingly prevalent condition in the ageing population, with around 25% of older adults in the community either at risk of malnutrition or identified as malnourished. This number is often unidentified, therefore it's potentially higher than 25%. Malnutrition is defined as deficiencies, imbalances or excesses in intake of essential nutrients, and it's characterised by weight loss and depletion of muscle and fat stores. We should all be aware of the risk factors and signs of malnutrition, and if it is suspected or identified, a referral to the dietitian should be made just so we can manage these. Now, these are just some of the risk factors for malnutrition, with the most common ones being known as poor appetite, oral health problems such as difficulties chewing or swallowing, changes to taste and smell, and also gastrointestinal issues such as nausea, vomiting, and diarrhea. Social isolation can also have a big impact on malnutrition risk, such as if patients are living alone, they have limited mobility or low income, as this can cause lack of access to food, lack of knowledge of nutrition or nutritional needs, or potentially limited cooking skills. Certain conditions such as dementia, mental health issues and infections are risk factors, as well as some medications or polypharmacy, as these can cause poor appetite and therefore affect oral intake. Now that we can identify the risk factors, these are some of the signs that we also need to be aware of. The most commonly identified are unintentional weight loss and muscle or fat wasting, and this is most evident in the upper arms, the lower legs, the face, the shoulders and the collarbones. Loose-fitting clothes or jewellery can also be a cause of this unintentional weight loss or body composition changes. If there is loss of interest in food and cooking, this should be a big sign, particularly if the patient previously enjoyed cooking. Changes to hair and skin, such as brittle hair, hair loss, and also poor wound healing, pale and dry skin can be signs as well, and of course if there is fatigue. So now that we've considered all of these big factors for frailty and falls, the aim of this evaluation was to determine the impact of dietitian intervention within a multidisciplinary geriatric outpatient service in respect to malnutrition and frailty risk. So this brings me to Strong Concord. So the Centre for Strong Medicine at Concord Hospital is a preventative outpatient service that integrates geriatrician, dietitian and exercise physiologist care to optimise the health of older adults and their well-being with chronic disease. Strong launched at Concord Hospital in November 2022, and it's based on the Balmain Hospital Strong service. The program is individualised and self-management is promoted to support patients to improve or maintain their functional status and independence and prevent hospitalisation and falls. To be eligible for this service, patients must be 65 years of age or older and be residents of the Canada Bay, Burwood, Strathfield or the Canterbury aspect of the Canterbury Bankstown local government areas, or be known to a Concord Hospital geriatrician. Eligibility will be based on the patient presenting one or more of these conditions that are known to be responsive to diet and exercise. Patients must also have a realistic goal of functional, health or mood improvements, and eligibility is determined by the geriatrician during initial assessment. And referrals are only accepted to Strong Allied Health from Concord Hospital geriatricians. So just to talk you through how the service evaluation was done. So this was done over the initial 12 months of service evaluation. Patients that were deemed eligible after geriatrician assessment were referred for a 12-week Strong program of concurrent diet and exercise physiology intervention with pre and post assessments. The outcomes measured during Allied Health assessments was malnutrition risk and nutritional status, measured using the mini nutritional assessment long form, frailty status, measured using the fried frailty phenotype, BMI or body mass index, and also diet quality using the Australian Guide to Healthy Eating. Now this is just to show you what the mini nutritional assessment long form looks like if you're yet to see it. And what it does, it's a validated tool that measures nutritional status and malnutrition risk in older adults. It is comprised of 18 questions that aim to cover the previously mentioned signs and risk factors for malnutrition, and it's based on a scoring system. So a score of less than 17 is considered to be malnourished, a score between 17 and 23.5 is at risk of malnutrition, and a score above 24 is well nourished or normal nutrition status. Now to talk you through the clinical interventions. So between initial assessment and reassessment in the Strong Concord program, there were 12 weeks of allied health intervention. Dietitian intervention included individualised nutrition strategies and education with a post-exercise protein supplement prescribed as clinically indicated. Exercise intervention was individualised, progressive and performed twice weekly, which included moderate to high intensity resistance training, challenging balance and aerobic exercise. After patients completed 12 weeks of the Strong program, they had medical follow-up with the geriatrician. So some of the results, between November 22 and November 2023, 111 patients completed a 12-week strong program with medical oversight. The average age of patients attending the service during this time was 81 years, and approximately half were female. This is all baseline data, and 59% of patients were identified as either pre-frail or frail, and 19% of patients were identified as at risk of malnutrition or malnourished. And now at the bottom, that goes through the body mass index categories for patients over 65 years of age. Now, a BMI between 22 to 27 is what we consider the healthy weight range for this population. So a BMI less than 22 is considered to be below the healthy weight range, and a BMI above 27 is above the healthy weight range. Now, as you can see, most patients that presented to the strong program during this time sat either within that healthy weight range or above. And just for your interest, these were the most common reasons for referral to allied health determined by the geriatricians, with the top three being to improve strength, prevent falls and preserve cognition, all of which can be a big focus in the strong program. So what did we find? After 12 weeks of strong Concord intervention, there was a significant improvement in nutrition status measured using the MNA, with 95% of patients now identified as well nourished. There was also a significant improvement in frailty status using the fried frailty phenotype, with 44% of patients improving their frailty status. BMI was maintained during this time, and these results showed no effect on gender. Now, in terms of the nutrition interventions, 54% of patients were prescribed a high-protein diet to optimise their health and achieve their goals. This diet is higher in protein than standard diets, and it's really beneficial for patients who have that goal of improving their strength or muscle mass, or potentially to reduce malnutrition risk or treat malnutrition. This intervention looks at including protein at every meal and snack that the patients are having, focusing on high-quality proteins, including a variety of animal and plant-based protein choices, as well as nourishing higher protein snacks, as you can see on the slide there. Now, to support this dietary change of a high-protein diet, 71% of patients were prescribed a post-exercise nutrition supplement twice weekly, and 21% were registered with the Home Enteral Nutrition Service for ongoing nutrition support. This saw 67% of patients improve their nutrition status through the addition of a high-protein diet and/or a nutrition supplement. Now, these are the supplements that were prescribed to patients post-exercise, and they were selected based on patient preference, tolerance, and costing. Enteral Plus and Fresibin 2-Cal are milk-based supplements, and the Resource Ultra is a fruit-based supplement, and these were both chosen to cover the different preferences of patients. And these were also prescribed to patients who required home enteral nutrition, which is a service that enables patients to receive these supplements at home to support their oral intake. On review, there was a 52% improvement in diet quality in relation to the Australian Guide to Healthy Eating, and this is a number that we hope continues to rise. Now, this is a food selection tool that's based on the latest evidence available to us, and it looks at really trying to promote health and well-being and reduce the risk of diet-related chronic diseases. It's comprised of our 5 main food groups, which you can see on the screen there, and it is different based on age and gender, so this is for patients over 65 years of age. And of particular importance is the meat, dairy and the alternative groups, as this is a big focus in the strong program, and also because it really looks at trying to optimise muscle mass and bone health, which is particularly important for frailty and falls risk. Now, this service evaluation was not without limitations, and these include the restricted capacity due to current staffing and service popularity with continued external referrals. More than 50% of our referrals come from external sources, and this causes us to use various waitlist management strategies, including prioritisation, education sessions, and additional triage points. However, as we can see from this evaluation, targeted dietitian intervention in conjunction with a tailored exercise program within a multidisciplinary outpatient service is successful in reducing malnutrition risk and improving frailty status in older adults. Further evaluation is required to determine the direct impact on falls and hospitalisation. Thanks for listening.
Thanks, Taylah. Are there any questions?
Thanks. Really interesting presentation. Thank you, Taylah.
Thank you.
Question, in your thinking or looking at the risk factors for malnutrition, was attitude to body image a consideration?
It definitely is a consideration. It can be something that we do see in that population, so it can be a risk factor. Thank you for bringing that up. But it's not a very common one, or not a commonly reported one in our service, but it definitely can be.
And in it not being reported, is that because people aren't aware whether the people actually have body image issues, or, in determining those factors?
It could be. It might be that it's not really talked about, or older adults don't talk about that, but it definitely can come into the nutrition assessment, and that could be a good idea to kind of gauge how common it is and if that is a risk factor.
Hi, thank you very much. A really interesting presentation. I'm interested in the BMI, because you said that we were looking, we should be aware of people who have lost weight.
Yes.
And who looked like they'd lost weight with their clothing, but actually then the people who were in your study had a higher BMI, is that correct, than you would expect in that group? So,
it's not necessarily a higher BMI than we expect. That's just the patients who presented to the service, but malnutrition can occur at any body weight, any BMI category. So it's still important to be aware of those categories, because it doesn't always mean that someone at a higher BMI isn't at risk of malnutrition or can't be malnourished. But it's just the categories we use for the ageing population.
thank you.
And I've just got a quick question. So you found significant differences. Can you comment on, for the mini nutritional assessment, whether that's clinically meaningful, a 1.5 point difference?
Yeah, it definitely is, and that's why I wanted to show you the scoring system for the M&A, because 1.5 points might not sound like a lot, but it definitely can push people within those categories. So that 1.5 difference can push them from malnourished to being at risk of malnutrition, or in that at risk to the above one, but it definitely can. Yeah.
Great, thank you.
Thank you.
Okay, so now I'll welcome up Dr. Marina Pinheiro, who's a Senior Research Fellow at the School of Public Health, Faculty of Medicine and Health, University of Sydney. And she's going to be speaking about the development and testing of a system dynamic model to project the health and economic impact of fall prevention initiatives in the community and aged care facilities. Whoa, that's a mouthful.
Thank you, everyone. And we're going to shift gears a little bit with this talk, as we could see based on the title. So what I'm going to be talking about is about the model that we developed to understand what is the impact of implementing at a population level interventions to prevent falls. I'll try and keep it not very technical, but please jump in if it's too confusing, and happy to take questions at the end. I don't think I need to spend time talking about the problem of falls to this audience. And as we saw in the first presentation, the fact is that we have an aging population, and if we don't take action, the consequences and costs of falls are going to increase with time. The good news is that many falls are preventable. We do have strong evidence supporting the effectiveness of a number of strategies to prevent falls. But the problem is that there is a delay and a slow translation of this evidence into policy and practice. And it is very complex, but one of the reasons that could be contributing to that delay or that slow translation is that we are operating in a very complex system. So it is actually quite hard to understand what is the impact of investments in fall prevention. Although we know that interventions work for fall preventions, it's not as simple as getting an effectiveness estimate or the impact of that intervention and doing a linear projection, because we are operating in a complex health system. We have the characteristics of that program that might vary, such as the reach, adoption, and attrition, and all of that will impact on the effect of that program. We also have the matters related to budget and willingness to pay of the people who are funding those programs. And we have the population dynamics in Australia as well. So we have a lot of people moving in and out of Australia, people transitioning to aged care, and even that rate of transition is changing as policy is changing. So we have more people aging at home instead of aged care, and these are all things that need to be considered. And of course, we have the interaction of all the factors that I listed above, and there are many other factors that I haven't mentioned as well. So it is quite complex. But the good news is that we have tools that help us to understand and make sense of that complexity. And system dynamic modeling is one of those tools. I won't go into too much detail, but it is a tool that is well suited for simulating nonlinear behavior that are complex in complex systems and that change over time. And we can understand and perform economic evaluations as part of system dynamic modeling. And the economic evaluation allows us to understand if we are to implement a new intervention or a new program or a new falls initiative, what is the additional cost and also what is the additional benefit for that. And that's quite helpful for decision makers to understand whether that intervention is worthwhile investing when you're comparing with other fall prevention interventions, but also with other interventions more broadly in health. So the aim, I'm sorry, is quite long again, Morag, is to develop and test a system dynamic model to project the health and the economic impact of fall prevention initiatives for people aged 50 years and older in the community as well as aged care in Australia during 10 years. So what we did for this project, we updated and expanded a model that had already been developed with the Sachs Institute that was focused on osteoporosis and related burden. So we started from there. And we used a participatory approach, which is considered the gold standard for this type of models, where we have a large group of multidisciplinary stakeholders, each representing different expertise, and we all work together to understand what are the things that we need to consider as part of the model and what are the systems that, and all the complexities that we need to take into account. For the model's input, we use standard procedures, which is looking at the literature as well as databases such as national and state database to make sure that we are feeding the model with the correct data. And we use Taylah Architect, which is a software for system dynamic modeling. And I won't go into too much technical detail, but we wanted to check whether the model was, behaving as we expect it to behave, whether it was a valid and accurate model. And for that, we did lots of testing, which we call validation. So the first one is called behavior modeling, where we look at the ability of our model to reproduce historic trends. So we go back in time and say, if the model didn't have the current data, is the model reproducing that historical trends? Because that gives an indication that the model is going on the right direction. We also looked at the face validity of the model, and this is done usually with stakeholder workshop, where we presented an overview of the model, we did scenario testing, and then we did model critique. And I think, Lorraine, you were part of that, one of the workshops that we did. The other thing that we did extreme condition testing, where we test the model using very extreme values, but yet plausible, so values that could be plausible, but that are unlikely, to see if the results are still reasonable. So we did a series of extreme condition testing. And also we identified a high-quality model that had been developed using Markov method, which is a gold standard in economic evaluations, and we compared the performance of our model, the new model, with that model that was developed using the Markov method. In that Markov method, they simulated 22 scenarios, and those scenarios, they involve changes in intervention characteristics or the population eligibility. So what we did, we simulated exactly the same scenarios, and we compared whether the outputs from our model were similar to what we found with the previous model. In terms of the results, we ended up coming up with a model that has 5 interactive components. Instead of modeling one specific intervention, usually that's what models do. They look at one specific intervention. So, for example, fall prevention interventions, and they focus on that. So instead of modeling one specific intervention, what we did, we designed the model with an interface that allows the user to change the parameters for the intervention that they want to model. So if you have the parameters for the intervention that you are interested, and if it is an intervention that has an impact on falls, you can use that model to project the impact of that intervention. So, but to give some guidance for the users, we use exercise as the default parameters in our model, because we do have strong evidence from the literature supporting the benefits for exercise. So this is what the interface looks like. The beginning of the interface, just give an introduction. We do have a dashboard that has lots of functions and you can do lots of things, but I'll just focus on, does that work? Okay, so here on the top, that's where we have the modeling for the community, on the bottom for residential aged care, and we can see the results in different ways. So we can see the health impact, the economic impact, and the intervention range. And there are many other functions here that we can export data and so on and so forth, but I'll focus on the basics. So let's talk first about falls in the community. This is a snapshot of the intervention that we put as a default intervention that we selected as part of our workshop, of our stakeholder workshop. So we are modeling a fall prevention exercise in the community. The effect size that we selected was 23% from the Cochrane review. That's what we found. That is overall how much, how much risk reduction we have in falls with that type of exercise. And here we are assuming that 5% of the eligible population would actually take up the program. So out of all of those that are eligible, only 5% would actually take up. We're using an age gap between to be eligible between 60 and 80, and we're assuming that it would take 3 years to full implementation of the program. So if we come here and we turn on the program and click play here, that's what we get for the output for the economic side. A lot of details here. I'll just walk you briefly through this. Here we have the cost side of things. Here on the bottom, we have the incremental cost, which is how additional funding and resources we need to move from business as usual to investing in this fall prevention strategy. But it does work. So we prevented lots of falls. You'd avoid a lot of disability as part of that intervention. And here are the incremental cost effectiveness ratio, which is a measure that Pip Logan mentioned in her talk today, that we use to see whether interventions are considered good value for money. These are in Australian dollars. If we use the UK guidelines that she mentioned, this would be below the £50 per DALI averted. But I don't want to focus too much on the results itself. I just wanted to show more the model and what we could do with the model. But let's say that you don't agree with the parameters that we have put there, or let's say that you want to explore different ways of rolling up that program. We can actually come here to edit the intervention settings, and that's where the user can actually manipulate lots of those inputs to see what would happen to the impact of that intervention. So let's say that you found out that you can actually deliver the intervention for less than what we put here was almost $1,000 per participant. So let's say that you have a cheaper way of doing it. That would be, $500 per participant. You could change this here and look at what is the impact of the program. Same thing for aged care. So now we have an intervention exercise again with a higher effectiveness. This again came from a meta-analysis. And when we run the program, we find a different sort of story here where we have a negative value here, which means that the intervention is saving us costs and is actually effective. So we say it is cost saving as well as effective compared to business as usual. So in terms of the validity of the model, we found good validity. So good ability to reproduce historical trends, high face validity. The model did well with the extreme condition testing, and also the agreement with the other model was quite high, it was 91%. So we do think we have some preliminary validity for this model, but we do think that we need further validation and testing. And particularly, we wanted to improve the policy relevance of the model. So the next stage, we are hoping to work more with policymakers to understand what are the questions that would be useful to be answered and how we can adapt the model so we can answer those questions. Some key elements that we have identified with our preliminary consultations are that we do need to consider equity consideration, so looking at whether the impact of interventions would be different in different groups, also consideration of population fall risk at baseline, and also we need to improve the falls data that we have supporting the model, because some of the data there was a bit sketchy, I have to say. But that was the best data that we had available. But there is room for improvement, working with partners to get, hold of better quality data. So in conclusion, we found good preliminary validity, although further testing and development is needed. And caution should be used when interpreting and using the results of this model. So everyone that plays with the model initially will be very tempted to change all the parameters and see what happens, and that's okay. But I think we need to be very careful on how we select those parameters, and we do recommend that selecting the parameters and interpreting the output should be done in consultation with stakeholder, with a multidisciplinary team, so we are carefully understanding what the model is telling us. I just wanted to acknowledge the wonderful team that has provided support to this, as well as participants on the workshops, including you, Lorraine, and as well funding from NHMRC for the project, as well as for my salary. Thank you.
Thanks, Marina. Is there any questions? All right, I'm going to ask you a question. Okay, I know you said don't worry about the results, but we're really all just interested in the results. So are you saying the model showed, maybe I misinterpreted it, that the community is not cost effective based on the model?
It depends on willingness to pay, right? So it's very hard to say whether something is cost effective or not, because it really depends. What I'm saying is that the intervention that we modeled is more effective, but it's also more costly. So whether it is cost effective or not depends on the willingness to pay of who is going to fund for that. And that figure that we have there is not very different to what the government is funding for medication and other medical services out there. So it's not that far from that. But in reality, I think even for here in Australia, for PBAC and MSAC, the approach is to try and see whether there are population groups that would be a more efficient way to spend funding.
And if we fiddle the books and instead of using 23%, use the 39% for those that are 2 to 3 hours, moderate to high challenge balance, what does that look like?
Yeah, exactly. And that's the power of the model, I guess, that allows us to explore that. But I think that all needs to be taken into account carefully, because then it's quite likely that the take-up might reduce and the adherence, the attrition will be higher if it is, So it's just considering all the moving parts. That's why we just need to be careful not to select random numbers and put it out there. So it's not random, it's not. No, it's evidence-based, but it's not linear. Remember that I mentioned it's not linear. It's, complex.
So can I just, if you've got the model, and you feel you can demonstrate that that's the amount of money you will need to be effective, then how do you use that to be persuasive to get that amount of money to be effective? And then what would the measures be?
Yeah, good question, Lorraine. What we have here is actually not what the budget impact would be. This is actually looking at everything, including healthcare utilization. So how much healthcare utilization is changing from one group from the other. But from the model, we can actually export what is the budget impact and how much investment upfront you need across all the years. So that's the other piece of evidence that I think is helpful in terms of understanding what sort of investment is needed over the duration, the rollout of the program. So we do have that embedded when we go to intervention reach. We can export that information as well. Does that answer your question? Yeah. Okay. Thank you.